Golden notes: acute upper gastrointestinal bleeding. This bleeding derived from a source proximal to the ligament of Treads. Causes: most commonly due to either peptic ulcer disease or esophageal varices. Risk assessment can use the Blatchford score at first assessment and the full Rockhill score after endoscopy. Clinical assessment: in fact, hematemesis is red with clots when bleeding is rapid and profuse, or black, the coffee grounds, when less severe. Syncope may occur and is caused by hypotension from intravascular volume depletion. Symptoms of anemia suggest chronic bleeding. Melena is the passage of black, tarry stools containing altered blood. It is usually caused by bleeding from the upper gastrointestinal tract. Although hemorrhage from the right side of the colon is occasionally responsible, the characteristic color and smell are the result of the action of digestive enzymes and of bacteria on hemoglobin. Severe acute upper gastrointestinal bleeding can sometimes cause maroon or a bright red stool. Basic investigations: CBC, chronic or subacute bleeding, leads to anemia, but the hemoglobin concentration may be normal after sudden, major bleeding until hemodilution occurs. Thrombocytopenia may be a clue to the presence of hypersplenism in chronic liver disease. Urea and electrolytes: this test may show evidence of renal failure. The blood urea rises as the absorbed products of luminal blood are metabolized by the liver. An elevated blood urea with normal creatinine concentration implies severe bleeding. Liver function tests: this may show evidence of chronic liver disease. The prothrombin time check when there is a clinical suggestion of liver disease or patients are anticoagulated. Treatment: resuscitation, ABC, wide bore intravenous access, platelet transfusion if actively bleeding platelet count of less than 50. Fresh frozen plasma to patients who have either a fibrinogen level of less than 1 gram per liter or a prothrombin time or activated partial thromboplastin time greater than 1.5 times normal. Prothrombin complex concentrate to patients who are taking warfarin and actively bleeding. Endoscopy should be offered immediately after resuscitation in patients with severe bleed. All patients should have endoscopy within 24 hours. In fact, recent NICE guidelines do not recommend proton pump inhibition before endoscopy. And he may have alcohol dependency and therefore should be prescribed Pabrinex whilst awaiting for endoscopy. Now, what is the Pabrinex? It is like multivitamin: vitamin B1, B2, B6, B3, vitamin C, and glucose. Now, the management of non-varicella bleeding, NICE do not recommend the use of proton pump inhibitors before endoscopy, although PPIs should be given to patients with non-varicella upper gastrointestinal bleeding and stigmata of recent hemorrhage shown at endoscopy. In fact, the best evidence for pharmacological intervention post-stabilization of bleeding peptic ulcer disease is for proton pump inhibitor. The most appropriate intervention to prevent further bleeding: IV omeprazole, reducing risk of recurrent bleeding of over 50% and reducing in the need for surgical intervention of approximately 40%. If further bleeding, then options include repeat endoscopy, interventional radiology, and surgery. Management of variceal bleeding: terlipressin and prophylactic antibiotics should be given to patients at presentation before endoscopy. Band ligation should be used for esophageal varices and injections of N-butyl-2 cyanoacrylate for patients with gastric varices. Tips should be offered if bleeding from varices is not controlled with the above measures. This was provided by the SSSM Study Smart series for Mrcp, your easy way to easy pass. Remember that the references and sources for the Golden Notes are Davidson, Oxford Handbook Series, Essential Revision Notes for Mrcp, and Notes and Notes. Don't forget to follow us on Facebook, Telegram, and YouTube channel. And remember, with SSSM, you're always in a safe zone and you're always the winner. Thank you very much.